One of the commonest problems we get called to in perioperative medicine and critical care is abnormal blood pressure. Usually it's hypotension, sometimes it's hypertension. You need to understand what blood pressure is, how it works, the reflexes that control blood pressure, and how we monitor blood pressure, in particular using arterial lines and oscillometers. An introduction to critical care, presented by me, your host, Pat Nelligan. Assessing the critically ill patient, interpreting and integrating the data. The section is cardiovascular assessment. When we get called to see sick patients, it is usually because one of the standard observations has triggered an alert. The temperature has gone up or gone down, the respiratory rate has gone up or gone down. The urinary output usually drops, the pulse rate may be high, it may be low, but in particular, we get called to abnormalities of blood pressure. The pressure is either too low or the pressure is too high, hypotension or hypertension. In this tutorial, I'm going to look at the blood pressure, what it is and how it is measured. And what I'm going to cover is the components of blood pressure, arterial lines, and oscillometry. Blood pressure is the force exerted on the walls of arteries derived from the pumping of the heart, that being the stroke volume. The left ventricle generates a pulsatile flow of blood that goes from artery to arterial to capillary. The force that moves blood forward is the blood pressure. Typically, this is defined as the cardiac output times the peripheral resistance, or the blood flow over time times the arteriolar impedance. To keep things simple, I'm going to define blood pressure as heart rate times stroke volume times arteriolar impedance. The stroke volume involves the venous return, the heart rate, and the left ventricular compliance. Typically, at the end of diastole, the right and left ventricles contain about 100 mils of blood. The ventricles then contract to eject out about 65 to 70% of that volume. The blood that is ejected is known as the stroke volume. In this situation, the stroke volume was 65 mils, and the ejection fraction, that proportion of left ventricular end diastolic volume that is still present at end systole, is the ejection fraction, 65%. Once blood has been ejected from the heart, then blood must flow back into the heart to start the next cycle. And we call that venous return. The ventricle relaxes, the atrioventricular valves, the mitral valve, and the tricuspid valves open, and blood flows in to the ventricles. Venous return is dependent on ventricular emptying, the heart rate, and the venous to atrial pressure gradient. The empty atrium is then backfilled by hydrostatic pressure gradients from the extremities and the splanchnic circulation. And this is the model that I want to follow for how the cardiovascular system works. There are essentially three circulations in the body. The pulmonary circulation, that's a low volume circulation. It receives the entire right ventricular cardiac output. And two systemic circulations, a fast compartment that flows into the brain and the extremity muscles, and a slow compartment that flows into the bowel and abdominal viscera. That's the splanchnic circulation, and it acts as a reservoir for venous blood. I want you to take note that the capillaries receive pulsatile flow directly from the heart, but the venous side of the circulation acts as a reservoir of blood that is partially pumped upwards by extremity veins and is delivered to the right atrium by a low pressure gradient that is enhanced by ventricular emptying. The heart rate, the stroke volume, and the total peripheral resistance exist in a dynamic equilibrium. These interactions maintain blood pressure and tissue blood flow. If one of the three becomes abnormal, the other two compensate. This represents the cardiovascular physiologic reserve. There are three different blood pressures that we typically measure and monitor. The systolic blood pressure is the peak pressure that is seen by the arteries after the ventricle ejects. The diastolic blood pressure is the resting pressure within the arteries. The endocardium perfuses during diastole, so maintaining diastolic blood pressure is essential to cardiac function. The third pressure is the mean arterial pressure. That's the average pressure within the arteries and the arterioles during cardiac cycling. MAP is essential to autoregulated organs. These are organs that maintain more or less the same pressure and blood flow continuously. Whether it's in systole or diastole, that flow just continues with the same pressure throughout. They're the brain, the kidney, and the bowel. The mean arterial pressure can be calculated as the diastolic pressure plus 1/3 of the difference between the systolic and diastolic pressure. I'll get back to that later on. Be aware that that is not how blood pressure cuffs measure mean arterial pressure, as I'll explain later on. An example of autoregulation is in the kidney glomerulus. Renal plasma flow and glomerular filtration rate are maintained constant over a range of systemic pressures by dynamic alterations in the tone of the afferent and efferent arterioles, and this is only lost at extremes of blood pressure. For the rest of the circulation, what controls blood pressure? The first thing is circulating volume. That's controlled by the brain and the kidneys, for example, the renin-angiotensin-aldosterone axis and antidiuretic hormone. By parasympathetic activity that tonically slows the heart, and sympathetic activity that controls vascular tone, systolic power, and increases heart rate. This is important because one of the major homeostatic actions of the body is to maintain mean arterial pressure within those vital organs, irrespective of position. Hence, when you go from lying down to standing to sitting, a series of autonomic reflexes activate that adjust vascular tone to ensure that flow is consistent. The major autonomic stress receptors are the baroreceptors in the aortic arch and the carotid arteries. The homeostatic control of blood pressure involves the parasympathetic nervous system that vaguely slows down the heart and the sympathetic nervous system that tonically constricts arterioles and venules. All of this is controlled by the vasomotor center in the brain. The other components are the heart that generates a right and left ventricular stroke volume, usually the same, and over time cardiac output, and the tonically firing baroreceptors. These are the end receptors for the autonomic nervous system that sense what's going on in the cardiovascular system. When the blood pressure falls, baroreceptor activity is reduced, and this results in reduced vagal tone, so the heart speeds up, and increased sympathetic tone. This results in an increase in both the stroke volume and the cardiac output from inotropy and chronotropy, and there is increased peripheral vascular resistance, and this all works to restore the blood pressure. And it does this very, very quickly. Now, as you get older, this is less fast. So for example, an elderly person who stands up from lying down or sitting down sometimes becomes a little bit queasy and faint because their baroreceptors haven't acted quickly enough. In the macrocirculation, for control of volume, there are a number of other mechanisms in play that controls both blood pressure and circulating volume. And this is the neurohormonal system that includes atrial stretch receptors, osmoreceptors in the brain, and the kidney, and in particular, the juxtaglomerular apparatus. Let's move on and talk about the measurement of blood pressure. Anesthesiologists and intensive care specialists love arterial lines. When we are medical students or junior doctors or nursing students, we learned how to measure blood pressure using a stethoscope and using a cuff with, for example, a mercury manometer. But these days, that is rarely done in hospitals. And if you go into the ICU, to the operating rooms, or into high dependency units where very sick patients are located or patients are having major surgery, you'll see patients with a line like this placed in their radial artery, for example. And we love these lines because when they're used correctly, they provide beat-to-beat measurements of blood pressure, allowing meticulous monitoring and careful titration of vasoactive drugs. The setup is standardized. Again, the favored position is the radial artery. Sometimes we use the femoral artery if we can't get access in the radial artery. We try to avoid the brachial artery because it's an end artery and the hand may become ischemic if it becomes thrombosed. You can use a standard 20 gauge IV catheter or a more sophisticated Seldinger catheter using a wire and then threading the catheter over the guide wire. The catheter is attached to a semi-rigid saline-filled tube that connects to a signal transducer that turns the pressure waveform into digital data that is visible on the monitor display. A pressure bag is inflated and that flushes the system, preventing blood from clotting. It also prevents blood from going back up into the tubing. Let's have a look at this in a little bit more detail. This is the radial artery with a 20 gauge catheter placed in it. Attached to that is a saline-filled semi-rigid tube that connects to a mechanoelectrical transducer. To keep this system patent, it has to be continuously flushed. So this is the flush tubing connected to a pressure bag that is controlled by a manometer, and the pressure is increased up into the high pressure zone that's over 200 millimeters of mercury by squeezing this little bag below that. Then a cable connects the transducer to the monitor. Pressure waveform fluctuations in the artery are transmitted into the catheter and then into the saline-filled tubing that serves as a pressure column. The transducer is an electromanometer that works a bit like a drum. It's displaced by the pressure fluctuations, then sensed electronically, and a digital signal is constructed from these data for display on the screen. There are a number of potential problems with this system. The first one is that the pressure bag is inadequately inflated, leading to damping of the waveform. There may be kinking of the catheter, there may be air or blood in the tubing, or clotted blood in the catheter. In any of these situations, the systolic and diastolic blood pressure may be misrepresented. The first thing that you must do when you've connected up an arc line is to calibrate it against atmospheric pressure. This is a process that we call zeroing. The transducer is turned off from the patient and is open to the air. This allows zeroing to atmospheric pressure. When this is done, the waveform on the screen will look like this, and 0 will appear on the screen. From that point, it is possible to get an accurate blood pressure reading. From time to time, it is important to check the resonance of the system, in particular to identify the problems that may occur with the arterial catheter system that I previously mentioned, and this is achieved by performing a square wave test of damping. First, you pull on this blue tag on the transducer component, and that flushes the system at full pressure of the bag. And once you let go and it stops, the pressure will fall back down to baseline, and there you will usually see between 1 and 2 oscillations. You need to count the oscillations. If there are several, there is a problem. This is an optimally damped arterial trace. Note the small overshoot after the flush test with 1 or 2 oscillations followed by a normal arterial line trace. This is what you want to see. This is an underdamped arterial line trace. You can see significant overshoot after the flush followed by more than 2 superimposed oscillations. This means that there is too much resonance in the system, and it results in an overestimation of the systolic blood pressure and an underestimation of the diastolic blood pressure. The mean arterial pressure is accurate. It's often really difficult to figure out why the system is underdamped. It may be a problem with the saline tubing, but we do know that the mean pressure is reliable. This is the waveform I want you to remember. It's an overdamped waveform. The response is really slow. There's a tiny oscillation beyond the baseline with no overshoot and a very smooth looking arterial trace without a dichrotic notch. Now this is problematic because it results in overestimation of diastolic blood pressure and underestimation of systolic blood pressure. So you might think that the blood pressure is lower than it actually is. Again, the mean arterial pressure is accurate. Why does this happen? This is what you see when there is an obstruction in the system. You need to have your own approach for working the problem. I start with the catheter. Now there are things you can see and things you can't see. What you cannot see is the tip of the catheter. So you don't know if there's a clot there, but you need to exclude all other possibilities. So the first thing you do is take down the dressing and make sure there isn't a kink. That happens quite frequently. Then have a look in the saline-filled tubing. There may be one of three things in that tubing: bubbles of air, blood clots, or a column of blood. You can close that off and suck out the air or suck out the blood clots, or you can flush the system using the pressure bag to clear out that column of blood. Often that column of blood is there because the pressure bag is inadequately pressurized. So push that pressure up above 200 millimeters of mercury. When you've got through all of that, check that the cable is intact. If you have failed then to sort out the problem of overdamping, there is an issue with the part of the catheter that's inside the artery. You may be able to live with this, or maybe you might have to replace the catheter. Be aware that the waveform may be different depending on where you place the arterial line. The further the pressure waveform is sampled from the heart, the narrower the pressure waveform and the greater the amplitude. So systolic pressure is higher and pulse pressure is wider in, for example, the dorsalis pedis artery than in the brachial artery. The other issue that's absolutely critical to measurement of blood pressure is the location of the transducer. And this is the correct location at the level of the right atrium. This gives you accurate blood pressure monitoring. It doesn't matter if the patient is sitting up, lying down, prone, in Trendelenburg or reverse Trendelenburg position. That transducer needs to be at the same level, the so-called phlebostatic axis. You need to be extremely careful with this transducer. If the transducer is placed too high, then the column of saline is above the blood level and there is underestimation of blood pressure. If the transducer is too low, it falls on the floor, for example, or the bed is raised, then there is an overestimation of blood pressure because the additional column of saline that is present from the catheter down to the transducer has an hydrostatic pressure effect on the transducer. Assuming that everything is done correctly, the monitor directly measures systolic and diastolic blood pressure. It then calculates the mean pressure as 1/3 of the difference between the pulse pressure on top of the diastolic pressure. And in this case, the systolic blood pressure is 120 millimeters of mercury. The diastolic pressure is 70 millimeters of mercury. So the mean pressure is approximately 86 millimeters of mercury. So in summary, regardless of where the arterial line is inserted, the transducer must be in the phlebostatic axis. So if it's in the back of the foot, if it's in the femoral artery, if it's in the radial artery, regardless of where that limb is, you've got to leave the transducer at the level of the right atrium. You have to ensure that the waveform is not damped or the line is not occluded with air or blood clots. Now, in general, this is the most accurate way of measuring systolic and diastolic blood pressure. The mean arterial pressure is also reasonably accurate, but not directly measured. Irrespective, this is the gold standard in the ICU. And when we have a hemodynamically unstable patient in ICU or in the operating rooms, we will place an arterial line. But it's not the only way that we measure blood pressure in hospitals, because this is what you usually see on the vast majority of patients on the wards, in the ICU, and in the operating rooms. And it's known as a blood pressure cuff attached to an oscillometer device. You may also have one of these devices at home, because these are now being sold as consumer devices for very modest sums of money. But if you go back to the early 1990s, this was a really novel technology. And when I was a young doctor, this was the device that was used practically everywhere. It was known as the Dynamap, and it was introduced in only 1991. It was the first fully automated non-invasive blood pressure monitor. It changed everything. But I think it's really worth remembering the name of this particular device, the Dynamap. And the main measurement that the Dynamap made was the mean arterial pressure. And that's why the map is over there on the left-hand side as the big number. And scooted across on the middle right-hand side is the systolic and diastolic blood pressure. And I'll explain to you now why that is the case. In this picture, on the y-axis, we have the cuff pressure in millimeters of mercury going from 0 up to, for example, 200 millimeters of mercury. And on the x-axis, we have time. When you cycle the blood pressure cuff, you push start on the machine, on the monitor, the cuff goes up from 0 up to what it thinks is the highest pressure the patient can have. Now, on the way up, on some devices, the blood pressure can actually be monitored, but typically what happens is the cuff goes up to a specific inflation pressure. It stalls there while the pressure stabilizes for a moment, and then it gradually deflates. You can do this stepwise or not stepwise. And along the way, as the cuff is deflating, it starts to notice oscillations. Just as the blood pressure is encountered, there's a thumping sound against the cuff. And these are oscillations, and they start small and they get bigger and bigger and bigger until they reach this point here, the point of maximum oscillation. And that point of maximum oscillation is the mean arterial pressure. And oscillometers are extremely accurate at measuring mean arterial pressure as long as the cuff size is correct. It then, from measuring the mean arterial pressure, it uses some black box algorithm technology to estimate what the systolic pressure was and what the diastolic pressure was. So this device is able to measure oscillations during inflation and deflation, but usually we see it as a deflationary measurement device. The air tubing connector does not need to be over the artery as it used to be when you were doing those blood pressures manually, because the oscillations are measured by the whole cuff. If there is a divergence between the cuff and the arterial line, check the arterial line transducer position, flush the line, look at the waveform, and if it's normal, believe the arterial line. It is almost always more accurate. Again, you got to make sure that you've got good husbandry on your arterial line. The systolic and diastolic pressure measurements on the oscillometer and on all oscillometers are guesstimates using black box proprietary algorithms. The systolic blood pressure is generally underestimated, and that underestimation increases as the systolic blood pressure increases. The algorithms are likely inaccurate in pregnancy, in patients with chronic kidney disease, in patients with diabetes, peripheral vascular disease, in patients with high body mass index, large arms, and in children. If the cuff is too small, the blood pressure reading is too high. If the cuff is too large for the arm, then it reads a lower blood pressure than is accurate. Just to reiterate that point, an incorrectly sized blood pressure cuff may result in inaccurate blood pressure measurement. If the blood pressure is lower than one would expect, make sure that the cuff is not too big for the arm or the leg. Let's review this tutorial. In this tutorial, we looked at the components of blood pressure, the heart rate, the stroke volume, and the peripheral resistance. I discussed that the circulation consists of fast and slow compartments. That slow compartment is the splanchnic circulation. As we will see in later tutorials, that is a really important component of your cardiovascular reserve when blood is lost. Venous blood is kept in a low pressure reservoir that is unaffected by the systolic and diastolic arterial pressure. Stroke volume, though, is determined by venous return and cardiac compliance. Arterial lines are the standard of care for blood pressure monitoring in critically ill patients or patients having major surgery. Oscillometers are used for everybody else, but they have major limitations in that they principally measure mean arterial pressure in a specific cohort of patients, such as young, healthy men. They may not work as well, for example, in women during pregnancy, in patients with non-compliant or over-compliant blood vessels. So they have their limitations, and the systolic and diastolic pressures are not necessarily that accurate. Next time, we're going to look at hypotension. And I'm going to explain what the difference is between hypotension and shock. And then we're going to explore a series of clinical scenarios that look at hypotension and shock, and I'm going to explain to you how to work the problem. I'll see you then, and I guarantee you'll learn something. So that was the end of the first tutorial on blood pressure. Next time we look at hypotension and shock. If you're enjoying the tutorials, please subscribe on YouTube, leave me some likes and comments, and follow my blog at ccmtutorials.org. If you have any friends you think might enjoy these tutorials, please pass it on. I'll see you soon.